Hi, I'm Cassie Ryan, and I'm going to be your instructor for this section. I was going to record myself just in that little voice thread circle, but then I realized that I didn't actually put myself in any of the other videos I made for this week that I've released. And I don't like the picture that was in the course intro video. So this is what I really look like. This is section 01. So the way we put people into sections is everybody in these two sections is in the direct entry program, and then we broke you down by track. So I've got the AGM students. I actually was a second bachelor's to nursing student myself. I'm the only person teaching this course who's not an NP. My graduate degree work is in public health, pediatrics, and psych, mental health. So I think that's predominantly what you all are. We wanted you all clustered because you've got clinicals, most of you, on Tuesdays and Thursdays, but the other group has full day classes on Mondays, and it just was becoming a problem for trying to find office hours that might come even close to not conflicting with your course schedules. So that's why you're together. But also, since most of you are in that clinical, there are a few things Beth wanted to make sure you get. And when you're looking at our assignments, there's a little note that says direct entry students, like click here, or a note for direct entry students. Look at that, because what we're trying to do is get it so that you can do the community you're doing for your clinical in this course, just to kind of try to compress your work and make it a little easier for you. So you certainly don't have to take us up on it, but it is an offer. So I go by Cassie, please call me that. She, her, hers. I am a pediatric RN who later went on to public health. I live in two different places, partially because of the pandemic and partially because we're mostly 9-month employees and because I like the beach. I've always been from the Boston area, like south of Boston, and I live in Hull now, so Nantasket Beach. This is where my family is. And usually I'm only here for a few months a year, but because of the pandemic and teaching online, I've been staying here longer and longer. As far as my hobbies are concerned, I like to knit, sit on the beach, and sit outside in the sun. And now I've started reading again. So these are all very sedentary hobbies that fit nicely. So like I think all of you, I didn't know I wanted to be a nurse, or at least I didn't realize that maybe I should go to nursing school when I got my undergrad degree. So I went to Holy Cross, got a degree in psychology with a minor in philosophy, so not super useful as far as the job market's concerned. While I was there, I did an internship at UMass Medical Center in the playroom in child life, and I got totally hooked and realized I really liked this. So that was maybe the end of my sophomore or beginning of junior year. And so then when I'd be back home around here in the summer, I started volunteering at what was Boston City Hospital. And then once I went back to school, I started volunteering at the CAP program, which was then the Children's AIDS program. It was a residential program, basically in the Dowling building at BMC. And kids with HIV, there was a daycare, and they would get dropped off in the morning with little taxi cabs. But also it was respite. So we had kids who lived there for years at a time, because this is back before we had good meds for HIV. Graduated, thought I wanted to do child life, and continued to volunteer and be back in the playroom. They also, when the person who was there was sometimes out if she was sick, would actually pay me to work, cover summers, cover Christmas. And I took my first semester of coursework and realized I am never going to be happy in the playroom. Like, my people are the nurses. I want to be where the action is. I want to be reading charts. So I realized I gotta not do this. So I finished my semester because I had started and paid for it. And then I took all my sciences and went to nursing school. I had to go out of state because back then they didn't have all these programs that were for people who were getting a second bachelor's. I knew I did not want to be a nurse practitioner. I had to apply to a nurse practitioner program to be a PNP. But in New York, they actually had, at that point, for licensing reasons, they had to stop at some point and say, here's your bachelor's and your NCLEX, like pass, see you next semester. And so about a third of us were like, see ya totally, and we left. Had I stayed in New York, maybe I would have gone back part-time and finished eventually, but I knew my goal was to be a nurse. So I became a nurse. in about an 18-month program. Came back, there was no nursing shortage, and I wanted nothing to do with med-surg. Happily, Boston Medical Center, which was City Hospital still, took me back. And I was very lucky. They had no new grad program. I was their first new grad in 18 months. They only took me because they knew me. And I basically just had a very personalized 6 months of close supervision. And I became kind of the floor project. Someone would say, oh, I have to urokinase support. Does Cassie want to see it? But I loved it. The work in general, loved working on the floor, hated rotating. If I ran the world, we would just pay some nurses more to be night people. I'm not safe driving home. I took the narcotic keys home once and had to come all the way back. This was before we had a Pyxis. I had trouble staying awake. I probably made all sorts of mistakes I don't even know about. So that was really difficult because otherwise I was working 2 12s and a 16 and picking up a ton of overtime and really enjoying it. At one point, I walked out overtired, fell, broke my arm, got a concussion. This is all what I've been told. I don't remember it. I remember leaving work at 11 because I was there late and getting up in the morning around 5:30 because I had to be at work at 7 a.m. and blood on the sheets. And when I looked in the mirror, my face was all cut up and I was sore. And I still don't remember most of that. But of course, I went to work. So I was sentenced to the primary care clinic. No idea why, because I couldn't do any. Well, first of all, I didn't know how to work in pediatric primary care. I didn't know the vaccine schedule. I did not know how to do telephone triage, which is really an important skill and a difficult skill. And I couldn't give shots because I only had one arm. But they sent me anyways. And I had a fabulous time for those weeks. Later on, when I was back on the floor, primary care had an opening and they let me know. And I took it and continued to work per diem on the floor. Eventually, about a year later, ended up in the sickle cell program. The person who was leaving kind of recruited me to take her job. And also we got some grant money and it started to become my job to coordinate the different sickle cell programs and look at things like, so what should be our best practices? When I was at BMC, I realized I wanted my kids to be able to go to camp. So Hole in the Wall Gang camp. So Paul Newman's camp, like you've seen his little face on your salsa and maybe on your ginger ale cookies or, spaghetti sauce. He started this camp in Ashford, Connecticut for kids with blood diseases, so cancer and other blood diseases. Started it with a physician from Yale who happened to do a lot of sickle cell, so it ended up being a lot of sickle cell and cancer and hemophilia. At that point, kids with hemophilia had gotten a lot of tainted factor that was pooled and they had HIV, so the camp also took in kids with HIV even if they didn't have hemophilia. So that's how they grew, and now that's still the backbone of their population, but more and more they've started to take in other orphan diseases. The truth is, we used to have 2 HIV sessions, and the US just doesn't make infants with HIV anymore. We test pregnant women, we prophylax them, we treat infants. So they basically ran out of kids, and so started bringing in other kids who don't fit with the camp mission, but can't go anywhere else. So glycogen storage disease, having to get cornstarch every 4 hours. A mito or metabolic disease on hyperal at night. So a bunch of kind of cool things. So I always enjoyed it. So during this time, I went back to school and I got my master's in public health and maternal child health. If you've been over at BMC, the BU School of Public Health is literally on the block next door. Even though it was so close, it still took me several years to finish because I was working full-time. Got the master's, and at that point, the grant had been through Children's Hospital and they had subcontracted BMC for me to do this work. So they hired me completely and I started to run their very large hematology program. So sickle cell was a little smaller. I was good with that. I knew that. But then I also learned all sorts of Gaucher disease and I did a lot on bone marrow failure, ITP, thalassemia. So it was super interesting because I've always liked learning new clinical things and looking things up. Once I was at Children's, I stayed at Hole in the Wall and eventually left Children's to go to graduate school. Stayed at Hole in the Wall, but I actually got off of sickle week because that timing of that week was bad and I didn't actually have to be a chaperone and ride in the bus anymore, and switched over to HIV and orphan diseases where I stayed for the remaining of my 20 years there. So I went back to public health, although saying it's public health is a little bit misleading because it was health services research. Everything was about medical care. Nothing was about public health. but my first degree was. So a lot of what we did, the project I was on, readmissions for veterans, validating statistical models, Medicare readmissions, really interesting stuff. I was working at the VA on a project. The schedule became a problem for me with school because I was TAing, and then I started teaching health policy. But the VA gave me really good health insurance, although they paid me poorly. So what I did is I went back to Children's where they paid me really well and didn't give me health insurance, and I purchased health insurance. Plus I missed nursing, and to be honest, it's just much more flexible. And so going back to nursing was great for me. I ended up going to neurology. A few of my friends worked there, and they were converting over to the new prescription system, and I was a super user. I was good with it. So I learned neurology while I was there, and I helped them all with the tech. So I finished my degree in health services research. My dissertation was very different from everybody else. Like, I've always been an outlier, no matter where I go. And I did access to bike share for low-income Bostonians through primary care. So how is it that we can take the fact that people need to get places and get bikes to where they are, where people live, work, play, pray, learn, and marry exercise to transportation? Because you can't expect, when people have financial stress, they have long commutes, they have a lot of competing demands, like they're not going to be like, oh, I'm going to take 2 hours for me time and travel down to the gym and have some exercise. So it was really about that. So your primary care provider could give you literally print out a prescription, which is more like a school note. And you could go to transportation. They would sign you up for a membership as long as you lived in Boston, because Boston had a $5 membership and you got a free helmet. You had to have a low income, but anyone on Medicaid, and pretty much, I don't think we ever sent over a patient who didn't qualify. And if you didn't have $5, we actually had a credit card and would pay your $5. We did not pay for the full membership. It was actually the city that had that existing membership, but people weren't using the membership. It wasn't well known. Often people who qualified for it financially don't have a big desktop computer at home to sign up and do all those things. So there were all sorts of barriers for them. So the goal was to stick it within primary care and see how it would do. Unfortunately, it was also the time when there were a lot of bike fatalities on Mass Ave and Com Ave. And when I did a survey, providers had very legitimate concerns about biking safety, and did their patients know how to bike. The other big problem is a lot of our patient population, when I looked to see who was referred, they were in South Dorchester and Roxbury and Mattapan. There really aren't bikes in most of those areas. Some in Roxbury along the corridor, but really no. So people signed up, but it wasn't where they were. So maybe if they were then taking a bus to Dudley, they could get a bike at Dudley or Ruggles. So maybe people still could use it, but there were problems. Also in Boston, we have bad winter weather, so it's not really a good year-round transportation. But the interesting thing is, when you look at people who bike a lot and bike commute, they're more likely to be male, young, higher income, higher education. When you looked at who got referred to get a bike prescription for us, way more females. It was pretty much even. And our average BMI might have been 37. So we did not have all these young, fit people. Maybe our average age was towards 47. So it really was an intervention for equity. So to say, for the people who have the most to gain from getting this exercise and transportation, how do we get them services? So that's the kind of project you're going to propose, not necessarily bike share, but when you do this project. So I finished, and then I became full-time teaching there, and I was teaching health policy, a health communications course, and undergrad public health. After I was teaching that for, maybe about 6 or 7 years, I heard about this job at BC. And it was interesting to me because half was the MHA program online, because I like technology, and half was supposed to be in person in nursing. So I'd be back in nursing, which was fabulous. The one little wrinkle is that what we didn't know is the state of Massachusetts, the Board of Registration of Nursing, the same people who set the picky details about how many hours you need and SIM and all of that, also have a rule that you can't teach an undergraduate nursing theory course if you don't have a master's in nursing. So I don't. I have a master's in public health, a PhD in public health, years of teaching experience and years of work experience in that area. But I had to be with somebody. So that's kind of how I ended up in the graduate course, but I really like the graduate course. So then I had to get a master's in nursing I did nursing education. It was kind of my pandemic project. Pretty bitter about it, but as you'll see, the board of nursing, they're not flexible. So you just got to deal with it. So now in the spring, I think I will be back with undergrads as well. I do the senior synthesis, and I taught one of the public health undergrad courses, and I'm going to start teaching the global health one as well. But every semester, including summer, I teach health policy at Woods. It's not really the healthcare policy you take. It's much more broad. It's not as focused on medical care. It's been a while since I've done clinical work, although I did become a COVID vaccinator for the state in February because I was losing my mind, locked up at home. And having worked in clinics for years, I had a lot of vaccination experience and I loved it. But they stopped using us. So I don't know with the booster if they'll have something for us again. But I did really enjoy that to the point where I think maybe I should get a job in primary care one day a week. What I'm super interested in currently is COVID policy, the public health and medical aspects of federalism. So you did that in policy with Medicaid. We're not doing any of that here. But we're going to look at things like state differences in policies. Like, why is it that I would have to wear a mask in one state? I can drive across straight lines and pull it off. Also FDA, because FDA is something that you don't have in that other healthcare policy course. And there's just so much happening with FDA, and there's so much misinformation about what it means to be authorized versus approved and how many people are in studies and the process that, as nurses, or nurse practitioners, you're going to need to be able to give patients accurate information. So we're definitely going to do something on that. And also some disaster preparedness. We look at it in the domestic local context of local public health of the Massachusetts example, but you can also think of it when you think about natural disasters like the wildfires in California. They actually make COVID more difficult because for COVID in a classroom, you'd like to open the window, but you can't if there's all that smoke. And also Haiti, which is pretty much in our backyard. And now we're seeing again a country with very little infrastructure, having an enormous disaster and really not having the resources to pull it back together again. And, kind of what is the responsibility of us, their neighbors, to be helping out. And also that actually leads into immigration policy, because temporary protected status is a status given to people to come and stay in the U.S. legally. It's not the same as refugee status. TPS is short term. But when there's a humanitarian crisis where you live, so natural disasters and wars often get people TPS status. We have people from Haiti and El Salvador who have been in Massachusetts for decades on TPS, because every time things are getting better in their home country, there's some other natural disaster and they end up staying. So they have no path to citizenship. They don't get benefits, but they are able to legally work. And so this earthquake is going to change the plan of TPS expiring there as well. If I could have any superpower, I would have the ability to basically take away people's driver's licenses in their cars. So I have very strong feelings about biker and pedestrian safety based on a lot of my dissertation work. And, it's not about blaming bikers. It's not about blaming drivers. It's actually about looking and saying, how do we use evidence to restructure our intersection so people don't get killed, so that we don't have conflict between bikers and cars and people. Unfortunately, that's not something a superpower could do. So what I would do instead is on both sides, walkers, bikers, cars, when there are things like cars parked in the bike lane, I just would maybe take your car away. So that's the superpower I would like. I know it's a little bit spiteful, but I used to bike in the city for years and I do have strong feelings. So this is an asynchronous course. So this actually has nothing to do with the pandemic. It's designed to be asynchronous because I believe that flexibility is good for students. I miss seeing people, even if on Zoom. So I will have a drop-in. I will do more drop-in sessions if people want them. I will put up my calendar. You can book right into Calendly and see me without having to make an account or have any back and forth. And what I do is I just put up a ton of slots and they disappear 12 hours before so that I know if I have somebody coming. But often I will have 6 days a week where there are slots you could use. So please, take advantage of that. We can talk through your project, work on the stuff you need, or if you just have you want to chat public health current events or policy or anything like that. Depending on how the pandemic goes on campus, I would be willing to see somebody on campus if they wanted to. I believe many of you are there on Mondays. Maybe we could bring beach chairs. But I don't think I'm going to be able to get a big enough room. I would love to do drop-in on Mondays in person, but I'm just not going to get access to a big enough room because the big rooms are used for classes to be able to do that, unfortunately. But I am flexible. So even though we are asynchronous, like you have a teacher who wants to get to know you and wants to work with you over the course of the semester. If you can never come to a drop-in and you don't want to ever have a one-on-one, that's fine. The real kind of theme of this class is these are your resources. Use what works for you and don't use the rest. Because that actually is what you do in the real world. You use what works for you and you don't use the rest. When you are in a clinical setting, you might be prescribing or giving a med. And for some meds, like the dosing for kids per kilo is literally burnt into my skull. I would never need to look it up. For other things, I have to look it up every time. So it's really just about knowing where are my resources, what do I need, what don't I need. So looking forward to our semester together. I do hope I get to at least virtually meet each one of you. And also feel free to email me as well. And that's about it.